morning. This is Dr. Al-Haddad. I'm a family physician at Lynn Community Health Center. I'm also a faculty at Tufts. I'm joined today by two of my colleagues, and we're going to talk about caring for the underserved population during the COVID-19 pandemic.
I'm Liz Quinn, Dr. Liz Quinn. I'm a family physician at Lynn Community Health Center with AMR, and I'm also faculty at Tufts, and I'm an associate co-director of the Sam Ho Health Justice Program at Tufts.
I'm Elaine Walter, the social worker for Moms Do Care program. I've been at the health center for almost 16 years now. I originally started as a medical assistant in a department called the Silver Team.
Liz, would you mind talking about Moms Do Care, kind of briefly introducing what it is?
Yeah, so Moms Do Care is, the Moms Do Care name itself is a grant program that the Massachusetts Department of Public Health runs. And they funded an initiative that we already had going at the health center that focuses on improving care for pregnant women and mothers with opiate use disorder. So Elaine knows, because she helped to found our initiative, that back in 2016, she and another family physician who preceded me identified that the women in the OBGYN department who kind of weren't being served well were women who were in recovery or who were actively using and wanted to be in recovery. And so they worked on a program to really have family medicine-based care that allowed for continuity from pregnancy to parenting and pediatric care that really provided wraparound services for this population. And then 2 years ago in 2018, we were able to get funding from Moms Do Care and really expand what we're able to do for the women we serve.
Yeah, it's a super powerful program, and Elaine does such a wonderful job with our patients.
Yeah. So
let's start. So I have a few questions for you guys today. Talking about underserved populations, we face our populations face certain challenges day to day, and a lot of these challenges are worsened during the pandemic. And I want to start off by talking about food insecurity. So how do we counsel patients about food insecurity, and in a setting where we're telling some people to stock up for 14 days if they're quarantined, if they have COVID, if they're suspected, or if one of their family members has COVID. And so for some people it's easy, but for some people with food insecurity already, it could be really challenging. So do you guys have any tips about how to counsel patients about that, and what we can do?
So I'll start by saying that I think the first step is that you have to ask. So it has to be a subject that you're actually bringing up. And I'm really proud that we had already been starting to screen patients in a formal, universal way for food insecurity. And that during this pandemic, our leadership, instead of saying, oh, well, that's an extra thing that we kind of can't deal with while we're dealing with this emergency, is actually saying, oh no, actually this is the time when we have to be screening our patients for social needs more proactively. And so now we're moving towards, instead of just a small subset of people asking about social needs and food insecurity, we're having across the health center, every telemedicine visit we do, people are going to be screened. So that's been something I've been really proud of. And then once you're having so you have to ask first, and you have to normalize it. So you have to ask by saying, wow, I've been hearing from a lot of patients that this is a problem, or it's really common right now that people are struggling with food insecurity, so that they realize that this is kind of an okay thing to talk about in the way that, we're recommending people do for the pandemic. And so the reality is that 1 week into their, social distancing time at home, you have to ask again, so I'm asking people every visit I have, every telemedicine visit that I have, I'm asking people about, how are you doing with food? What's going on with food for your family?
So
Yeah.
what are food options? What are safe food options that people with food insecurity have right now? Because I know that some shelters offer meals, you have a mobile market, but all those involve a lot of social contact. So Yulaine, I guess this is a question for you, and if you can just briefly tell us, like, what are the safe food options that our patients have?
Well, with us in our area, we're fortunate that we do have like Brothers Table, and they are not letting clients eat anymore inside, but they actually have to-go meals ready for them, so they can just walk up and grab the meal and go. But with some of my clients, we've actually made a list of what foods that they can get from food pantries or that they have on stock, like peanut butter. Sometimes bread only lasts a week, and if they're really experiencing like difficulties, like if they're homeless or in a shelter, we talk about having crackers versus bread. We talk about like cereals. We talk about like nuts and trail mix, things that they can have. Yeah, and even like I know like one of my clients, she shops mostly at the Dollar Tree, and so she had like the packages of tuna that come in, so she can have that. You talked about apples, how they can last like 14 days. We actually Googled it at the health center a couple of weeks ago. Because a lot of our patients are already dealing with not having electricity or not having gas. They're in severe circumstances.
And I guess that brings me to my next question is, which you already talked about a little bit, is housing insecurity, which a lot of our patients face. What can we tell people about housing, that have housing insecurity, about how to socially distance and how to quarantine themselves in a room if they have symptoms or if they're tested positive? Do you have any ideas about that?
That is a little bit more harder and challenging. I know that the emergency shelter in Lynn, as of almost a week and a half ago, they weren't taking any new intakes. And I do know, because I used to volunteer at the shelter in Lynn, that the residents are the ones who actually clean it. So,
it's a risk in its own self, right?
Yeah.
I know that sober homes and other institutions like this also have a lot of shared living spaces. Are any changes happening with that?
Not that I'm aware of. I just know that they're kind of telling the staff to check in over by the phone. One of the girls I talked to the other day on the phone, she and her roommate, because they actually share the living room and the kitchen, but then they have their own separate bedrooms for EA shelter.
That's a classic example of congregate living, which is part of the screening for COVID-19. Yeah, sorry.
They have like this thing about who's cleaning on which day. It's hard when they have younger kids, because one of the roommates has like a 2-year-old. But they've been in their apartment, so they feel like they're not going to have it. But it's scary. It's scary for them.
Yeah, so I'll add that when we think about shutting down appointments or not having people come into the health center, one of the risk factors that we all thought about medically: older age, greater than 65, having medical comorbidities. But one of the ones that immediately came to mind for me was, congregate housing. So many of our patients are in congregate housing, and so the idea of like expanding their touch network and their germ network even further by having them come into the health center for a visit, that maybe wasn't necessary, seemed especially concerning to me. So, I think our team really very quickly, as soon as the week that the state of emergency was declared in Massachusetts, we were really starting to empty our rolls of patients and calling people. But the other piece is kind of keeping an eye on the public policy that is, potentially either improving or worsening inequity in our society. And so, Massachusetts has done some, has made some good moves. For example, in the EA shelter system where many of our patients live, it's the family shelter system in Massachusetts. Usually, if you're away from shelter for more than a day or two, they will take away your shelter space because they're saying, look, you clearly don't need this. You're able to go stay someplace else. During the pandemic, they pretty quickly said, okay, you're allowed to be away for 2 weeks or more. And so if people had another option to be, at a mother's house because it's a pandemic and the mother would allow it during this situation, but usually doesn't, they were able to take advantage of that. So I was really reassured when I called one of my patients who has a 3-month-old baby, and she has some significant comorbidities that put her at risk. And I knew she was in an EA shelter and didn't have a lot of other options. But she said to me, I feel a lot better because a lot of people have left. It's much less crowded. There's fewer of us to be kind of sharing germs with one another. And so she felt more at ease.
Absolutely. Just to branch off on that, so EA shelter allows them to leave now for 2 weeks to be with other family if they can. But the SNAP program for food stamps has also given an extra supplement for families to have food. And if they weren't getting the maximum amount of food stamps for the next 2 months, they're allowing them to. So a family of one can get $194.
Is that a week?
If they were, say, getting, like, if they were working part-time and only getting, like, maybe $20, they're going to give them the maximum for the next 2 months.
Okay. That's great.
So, which is something new that they've
never done before. Okay.
Yeah.
So I want to move on a little bit because we're running out of time. Dr. Quinn, can you just comment a little bit about what we're doing for patients with opioid use disorder that are on medication-assisted treatment during the pandemic, and what the changes are, just briefly?
Yeah, so it's quite a few things. So we at our program, and this is following the lead of the Boston Medical Center OPIOD program as well, we've suspended required urine drug screens. Usually we have a policy that if you pick up your Suboxone prescription either weekly or monthly or every 2 months, that when you do that, you give a urine drug screen. We've suspended that because we think that's too much exposure to germs. We've also, with concerns about supply, so there's real concerns that we could have issues with the supply chain of actually accessing Suboxone. And so we have now made it a policy that for most patients, we're offering a 1-month supply with 1 refill. And my patients were all very surprised when they saw those prescriptions.
Really unusual for us to do.
And
our usual is a week supply, and we'll have an in-face appointment, and so forth.
And sometimes we'll move up to a month supply for some people, but rarely do we ever do a refill. But we really wanted to make that something that people would have access to, even if the clinic shut down or one of us is quarantined and not coming to work and therefore doesn't know that person. We really wanted to make it so that there'd be as few barriers to accessing medication and therefore preventing overdose as possible. We've again been helped by public policy in this regard. So just this week, SAMHSA, the Substance Abuse and Mental Health Services Administration, has come down saying it is okay to do telephonic Suboxone starts. And that's huge because I've already during the pandemic started someone on Suboxone. And the first time I saw her, we were able to do an in-person visit. I was working urgent care, and she had recently had an overdose. But she then disappeared for a little while. Things were hard for her. And then she called back, and I was able to, continue her script. It wasn't really a continue, it was a restart. But that's life-saving because the opiate epidemic is continuing. It hasn't stopped because of the pandemic.
And I think if anything, it might worsen during the pandemic because of the stress and the isolation. And that being said, so a lot of all meetings are canceled, like all NA, AA meetings, all support meetings are canceled in person. They have moved online.
Some of the methadone clinics weren't getting clear guidance on what should they do. And we've really taken it upon ourselves to advocate for patients to say, look, this is someone who has medical problems, she cannot be going daily to wait in line with a lot of other people. You need to work on take-home doses.
So great conversation. Thank you both to the both of you for joining us. Yeah, so we'll just end there. Is there any other last comments that you'd like to share?
Just want to say I can't wait until we can have tough students back at the clinic.
Yes.
Yeah.
Exactly. Absolutely. Everyone misses tough students at the clinic.
Yes.
They're very helpful.
Yes.
Great. Okay. Thank you. Thank you. Have a good day.
Thanks so much, Amr.
Bye.